The respiratory system that we do today demands that we have to dissect the head and the thorax differently and separately to make it more convenient, because the respiratory system then is divided into the upper airways and the lower airways, or upper and lower respiratory tract. The upper airway dissection of the head then demands us to make special paramedian cuts, also removing the horn, and you can see the frontal sinus in there. And I reflected the left-hand side of the maxilla by that paramedian cut so that we can look into the nasal cavity. And while we've got this side here, I'll explain it better on that side, but one can see the different conchas here. But to make it better, I use that side, and after removing the cartilaginous nasal septum, we can see into the right nasal cavity and how it's divided, and most of the space being used up by the different conchae. That is the dorsal concha, the ventral concha, the middle concha, and these are the ethmoidal concha. And as one can see here, they displace most of the nasal cavity. So the nasal cavity volume is much smaller than one would think. And these conchae divides the nasal cavity in a dorsal nasal meatus, a ventral nasal meatus, and a middle nasal meatus, which is split into a ventral and a dorsal channel. The ethmoidal conchae, they also have their own ethmoidal meatuses. And then the last meatus is, if we consider this nasal septum in its position, then the common nasal meatus would be between the conchae and the nasal septum. Now we have to consider that because air comes through the nasal cavity, the temperature is warmed up, the humidity is pushed up to purely saturated air, not to damage the lower respiratory system. And then one must realize that the nasal septum divides the caudal exit of the nasal cavity, and with the instrument there, through that right-hand side guana, or caudal nasal opening, touching the rope there, because the rope indicates to us the whole pathway of the nasal passage on that side. If I can grab that rope there. And on this side, because the nasal septum has been removed, as I said, and the left-hand side maxilla, the left guanae would be between this caudal end of the nasal septum that is free and the left maxillary region. So air then goes further through, and this part here would be the nasopharynx. The nasopharynx, that is that area there with the rope there, it's important because there are openings into the nasopharynx, for instance, the Eustachian tube. So if I reflect this and my instrument, my assistant passes the instrument, the probe, into the Eustachian tube, you can see where it enters there into the nasopharynx. And the Eustachian tube connects the middle ear then, the middle ear cavity to the nasopharynx to equalize pressure on the inside of the membrana tympanica, that is the eardrum. Then another opening is the opening of the nasolacrimal duct in the vestibulum of the nose. It's too small for us to see. But while we've got this shot here, we can see the frontal sinus there, also where the horn was cut off. We can see another remnant of the sinuses, that is the maxillary sinus in the palate, or the palatine component of that. The paranasal sinuses drain, except then for the frontal sinus, the other paranasal sinuses drain in the middle nasal meatus in the opening there, whereas the frontal sinus drains in the ethmoidal meatuses. So the upper airways goes on then, and if we zoom in from there further, we can now look at the other components of the respiratory tract. Right, air then moves from the nasopharynx further down, and that is dorsal to the soft palate. So that being the hard palate, this the soft palate, and that the caudal edge of the soft palate. Air then moves further, but in the normal animal, the epiglottis, which is that one, is positioned dorsal to the soft palate's caudal edge, like that. So if I can grab that with the instrument, air then goes down over the epiglottis straight into the trachea to come out there. In other words, the pathway of air indicated by that rope crosses then the pathway of food as indicated with my finger moving there and upwards into the esophagus. If I can let go there, because what happens is that the epiglottis folds backwards during swallowing. To demonstrate the difference between the pathway of air and the pathway of food, we put a plastic into the pathway of food, and I've got the epiglottis here in my right hand in that instrument, in the forceps, and the wall of the pharynx here in my left hand and that forceps. And we can see the rope which we had into the respiratory pathway. So first, if I put that epiglottis back, then the angle of the camera would be to show the vocal cords there in the depth where the rope passes through. And during swallowing then, what happens is that the epiglottis folds backwards and over the vocal cords also close. Then also what happens is that the palate's caudal end pulls tight, and these palatopharyngeal arches, the left on this side and the right on that side, pulls tight, closing off the ostium intrapharyngeum, which I'll try to show, which lies between that side and this side. It closes off, and therefore food cannot go into the respiratory tract, but it has to follow the pathway of that red plastic up and down into the esophagus. The pathway of food then travels dorsal to the tongue and on the sides of the tongue in the oral cavity proper. As it goes further caudally and during swallowing, the epiglottis would fold backwards and the vocal cords would close and the ostium intrapharyngeum would close. In other words, food cannot go back into the nasal cavity, and food would then travel along the direction of that rope in the esophagus and down the cervical esophagus in the neck region. We all know then that the pathway of food and the pathway of air would cross like that, and the mechanism of the epiglottis and the vocal cords is part then of the mechanism to allow that to happen, and at the same time the closure of the ostium intrapharyngeum to prevent food going back into the nasopharynx. The lower respiratory tract extending then from the cranial end of the trachea, then through the thoracic inlet, which are opened up a little bit more so that we can see the blood vessels that go past here, and more importantly, the position of the esophagus, which is at about 10 o'clock. If we take a cross-section through the trachea, then its position at the first rib is also more or less like that, but to the left of the trachea. But caudally, it goes further dorsal. And that is part of the digestive system, but that basic topography is something that we should consider at this stage then. Then the left pleural cavity and the right pleural cavity, we know from the first practical that that develops from the pleuropericardial cilium, also the pericardial cavity. And the most cranial extent would be the cupula pleura here, which is bigger on the right-hand side, but this dissection concentrates on the left-hand side for practical reasons. And the most caudal end of the pleural cavity would be there where the pleura on the diaphragm reflects on the inside of the ribs, and that is the line of pleural reflection. And the space or the potential space between the basal border of the lung and the line of pleural reflection is the recessus costa diaphragmaticus. So we cannot see much of that because the lungs have collapsed, and in this case we see that the lung is mottled. It's not because of pneumonia, but it's because of inhaled blood when the animal's throat was cut. So in this dissection that I prepared it with a little bit of emphasis then on the arterial supply and the venous drainage. So therefore it is best for me to reflect the lung and keep it in position with the instrument so that we can look at the structures on the deep side, because that is where I will discuss the arterial supply and the venous drainage. This being the left-hand side, that opening was cut into the left ventricle, and that opening was cut into the right ventricle. And that is in order for us to see the origin or ends of the blood vessels that are involved in the arterial supply. Now, this structure here is the conus arteriosus, which goes over into the pulmonary trunk. That being the aorta, and that structure we've done, that is the ligamentum or the ductus arteriosus, which is a fetal remnant. So to orientate, that being the arterial supply to the lungs, it comes from the right ventricle, and I've got an instrument in there. Then the arterial supply splits, and we can see that there's a right and a left pulmonary artery, and I've got the other one also there. So this is the right pulmonary artery supplying this lung. And then after all the branching and supplying the alveolar, it comes back as the pulmonary veins, and I'll pass the instrument into one of the pulmonary veins, draining this left-hand side lung, and it drains into the atrium, the left atrium, which I've exposed there by cutting a window into the left auricle. So the venous drainage from the right-hand side lung would also be into the left atrium, and from there it goes to the left ventricle, and from there the heart would pump it back into the systemic circulation, if I can pass that instrument in there. And as you can see, that goes back into the aorta, which is the high-pressure systemic circulation. The lymphatic drainage of the lungs then start as small lymphatics in the subpleural areas, and it drains together towards the pulmonary lymph nodes, and there are 3 at least at the tracheal bifurcation, and some of that lymph can also go to the caudal mediastinal lymph node. If I reflect this lung in that direction, that is the caudal mediastinal lymph node situated in the mediastinum, and from there it goes to the thoracic duct, and eventually the thoracic duct joins one of the large veins here in the cranial mediastinum, usually the left subclavian, and the lymphatic drainage then, or that lymph then goes back into circulation. So having done the lymphatic drainage, the arterial supply, as well as the venous drainage, we covered the circulatory supply to the lungs.